I hope so. You never know until you're It is
Okay, I think we'll get underway. Welcome to the fifth in our series of AARP Andrus Gerontology Center Distinguished Lecture Series. And I want to welcome you all here. Many of you have heard my preliminary spiel, but I'll give a little shortened version of it because these lectures are being taped by us, and AARP and in partnership with us will be distributing them. They're also available on our website. You see a somewhat wordy rendition of our mission statement to get a sense of what we're all about. The Davis School itself was founded in 1975 as the first school of gerontology in the world, and still one of the leading, if not the leading school in the world. We're very well known for our research and education in this broad field called gerontology. Some people call it aging studies. We study people and do research in the whole lifespan from before birth through the senior years. And on our faculty are people who are psychologists, biologists, sociologists, and public policy experts. And one of the unique features of this as a school is that it's truly interdisciplinary, that these different scientists and educators, with their students, examine the complex issues relating to the aging process and aging, again, over the lifespan, and do it collaboratively and in a truly interdisciplinary spirit. So it's one of the things that lends uniqueness to our enterprise that we're very proud of, and it's a privilege for me to have been dean of the enterprise for the past couple of years, and to be a part of this group. One of the great things about our partnership with the AARP is this lecture series. AARP recently celebrated its 50th anniversary, as some of you know, and one of the things that they wanted to do was to, part of their celebration, was to have an academic or a lecture series at a university, and they thought of us first, which is appropriate, but also a great honor and something that this school, way before I came on board, earned in being in such high standing in their regard. So they are underwriting this series, and I'm happy to say that they're happy with what we've been able to put together. Our speaker today, Dr. Henry J. Aaron, follows in the part of the tradition of the outstanding speakers that we have had so far. As part of what you received when you came in is a brief bio about him, so I won't repeat a lot of what's in here. What I thought might be interesting to do is to just give you some context for what the Brookings Institution is, and knowing that Dr. Aaron is one of the leading figures in that institution, I think will give you a sense of how what a great privilege it is to have him here as our speaker. The Brookings Institution is a nonprofit public policy organization that's based in Washington, D.C. Their mission is to conduct high-quality, independent research, and based on that research, to provide innovative, practical recommendations that advance three goals. One is to strengthen American democracy. The second is to foster the economic and social welfare, security, and opportunity of all Americans. And third, to secure a more open, safe, prosperous, and cooperative international system. Those are very noble goals. The Brookings is consistently ranked as the most influential, most quoted, and most trusted think tank. And barely a week goes by that some expert, for example, Dr. Aaron, is quoted or his work is referred to in educating the public about important developments that affect social policy. Recently, in Foreign Policy magazine, they have a think tank index, and just in this past January, it was rated the number one think tank, number one for impact on public policy debates, number one for international and security affairs, number one for international development, you see a pattern here, number one for international economic policy, number one for health policy, which is very germane today, both today nationally and today in our lecture, number one for domestic economic policy, number one for social policy. So whenever debates occur in Washington, whether it be over Middle East, peace issues, or global finance or urban strategy, it's a fair bet that Brookings is driving the conversation. From health care reform to recommendations on closing the prison at Guantanamo Bay, Brookings has a breadth of experience that allows it to offer innovative fixes for nearly every critical issue facing the United States today, and that's a quote from Foreign Policy magazine. So it's with great pleasure that I introduce to you Dr. Henry Aaron.
First thing I have to do is get geared up here. I'm sorry?
The computer restarted.
Oh,
Sorry about that.
okay.
Let's find out what's going on. There must have been a power outage for a second.
Just so long as it's before I start to talk.
Okay.
I know. Yes, it is.
Okay, good.
There we go. Thank you very much. I noted from Dean Davidson's introduction, AARP is now old enough to join itself, which raises images of somehow things imploding and vanishing, but
One more thing. Sorry.
yes, I can see that.
Sorry.
We want to
Sorry.
thank you. When I was asked for a topic some months ago, I came up with what you now see on the screen, and I was concerned at first that it was way too wordy and way too long, but I was assured that it was descriptive and therefore that it was suitable. It is exactly what I want to talk about today. This being a university, it seems appropriate to begin with, however brief, a quiz. So this is a one-question quiz. And the question for you is, what do all but one of these presidents have in common, and which is the one that doesn't? Well, the answer is every one of the presidents here, both Republican and Democratic, dating back to the beginning of the 20th century, have embraced large-scale reform of the U.S. healthcare, I hesitate to use the word system, healthcare system. I hesitate to use the word system because that implies a degree of organization and coordination that is not an accurate characterization of the melange of arrangements that we have here in the United States. The exception, of course, is President Obama, who is beginning what he hopes will be a process of reforming the U.S. healthcare system. Why do they keep on trying? Why do they keep on failing? Why are chances better now than ever before? And why, even if things go as hoped, is the process of healthcare reform going to be one that may be begun in President Obama's administration or administrations, but will not be completed in that period of time, rather will continue for many presidencies? Well, let me start with the first question. Why is it that they keep on trying? There is a triad of problems with the U.S. healthcare system that defines the answer to why they keep on trying. The first is cost. We're all aware of the fact that the U.S. healthcare system is fabulously expensive. $2.5 trillion estimated for calendar year 2009. Per capita spending, on the average in the United States, higher than that, twice as high as that of the 10 other richest countries in the world on a per capita basis. That two times number varies a bit, surprisingly and capriciously from year to year, because you have to convert dollars into pounds or euros or yen, and it turns out that exchange rates vary from year to year, and that injects a measure of static into the comparison. But 2 to 1 is about what it is. The second reason is quality. Americans for many years, and still to a surprising degree, are fond of congratulating ourselves on having the finest healthcare system in the world. That probably isn't correct, but even if it were correct, it's no cause for self-satisfaction. It probably isn't correct because international comparisons do not place the U.S. healthcare system at the top of the heap. The World Health Organization places us somewhere around 35th, just about where Costa Rica is. First prize, incidentally, goes to France. Now, the World Health Organization may be attaching a great deal of weight to the fact that we don't cover everybody here, and may be downgrading us excessively, by some lights, on the basis of not being fair to those who are uninsured, and may not be giving sufficient weight to the outstanding quality that is available when U.S. healthcare system is operating at its best. But however you slice it, we don't come out really at the top in these international comparisons. Even worse, we don't come out very well by comparisons with standards of excellence that have been published and studied here in the United States. The most famous of these reports is that of the Institute of Medicine that found close to 100,000 avoidable deaths annually from medical mistakes or failures to provide recommended services. A second study, in many ways even more damning than the IOM study. After all, people do die eventually. If they didn't die this year, maybe it would be next year. So the real implication of the IOM study is that people died earlier than they otherwise would have. But another study reports that only about half of people in a random contact with physicians or with hospitals receive all the recommended care for the condition that brought them to see the physician or enter the hospital. The reverse fact is obviously true. Nearly half of people don't receive recommended care in a random contact with physicians or hospitals. Unless you think that this is a problem just of the poor or just of minorities, the striking thing about this study was that the failure to provide recommended care was equal opportunity right across the board. Rich and poor, old and young, black and white, males and females. Pretty much the same. It didn't matter. It was nearly 50% not getting recommended care in all groups. There was one exception where about 70% of patients received all recommended care. Still not good enough for an A in any class I know, but better than average. That was the VA system, which is fascinating for a couple of reasons. One is the VA system until maybe 10 or 15 years ago was the perfect sinkhole of bad medicine in the United States, and it's been transformed to a very significant degree. And the second thing is, although Americans have no patience and no particular interest, according to all public opinion polls, in imitating the British National Health Service, the VA is the closest thing we have within the borders of the United States to the British National Health Service in terms of organization and management. So quality is the second reason they keep on trying, and then the third reason, of course, is access. These are statistics that I'm sure you all know. 45 million people uninsured at a given point in time, more suffering episodes of lack of insurance over extended periods of 2 years or so, many fewer continually without care, but nonetheless a very serious problem. The estimates being that on the average, the uninsured consume about half as much health care as do the insured, and that gap tends to reflect treatments, diagnosis, and early treatment, screening examinations, not so much treatment for extremely serious illnesses. If you present at an emergency room, hospitals take you in and they treat you. And they have to meet basic standards. The poor may not receive presidential medicine in such cases, few of us do, and they may not even receive the care that most of us would expect as standard, but they are treated, and they are treated to a reasonably high standard in the case of serious diagnosed conditions. But short of that, relief of pain and suffering, treatment of chronic illnesses, if you have diabetes or something of that sort, the poor do not do well, and the uninsured. Now, why do all of these presidents keep on failing? It's a fundamental question, because in order to hope to succeed, you've got to deal with those problems. The first reason is that despite the fact that most of us are absolutely convinced that the healthcare system as a whole needs attention and radical surgery, if you ask most Americans, and I suspect most of us here, you had a pretty good experience the last time you saw a doctor. You weren't unhappy. You trusted him or her. If you had surgery, the hospital did all right by you. Your experience, nobody likes to go to the hospital for surgery, but you were probably reasonably well treated and would put something at the upper end of the scale as a result of your experience. You're worried about cost. But why are you worried about cost? The reason you're worried about cost, I won't say you, most people are worried about cost, is that they have to pay too much out of pocket at the time they need care. Well, that means that people are not anxious to do anything to the healthcare system that they fear might jeopardize their experience in seeing a physician or in going into a hospital, and they're going to look fishy-eyed at any proposal that might entail limitations on their access or that would significantly change their access to physicians and hospitals. And they're going to look with suspicion on something that might ask them to pay a little bit more out of pocket at the time they get sick. Well, all of those things are going to have to occur as part of health care reform. And for that reason, there's a great deal of self-protectiveness, suspicion, distrust of Washington that makes getting the healthcare reform effort underway very difficult. The next thing is the sheer size of the system. The number I gave you, $2.5 trillion in 2009, just to give you a comparison point, that is equal to the whole GDP of France. So when you're talking about reforming the U.S. healthcare industry or changing it, you're talking about changing something as big as France. That's hard to do. It's very hard to do in one bill. And it's one of the reasons, for example, why President Clinton became a cropper. Not the only one, but it was a major consideration. It's complicated. $2.5 trillion doesn't all get spent buying in the same way a relatively uniform product. It is a summary total for jobs for 20 or 30 million people, for scores of different industries producing different products with conflicting interests and different technical problems that need to be addressed if you want to change the way in which they deal with healthcare delivery. Of necessity, large-scale health reform is bewilderingly complex. So complex, I don't think anybody fully understands. I know I don't. Fully understands what the ramifications beyond the immediate impacts of most of the large-scale reform plans that have been put forward. And finally, it would be nice if there was some sense of agreement within the U.S. political system about how best to do the job. But on the left, you have people believing that if we would just enroll everybody in Medicare, the world would be a better place and our problems would be solved. You have people on the right who believe if you simply provided the poor with enough money and turned individuals loose to buy insurance and to deal with providers as individuals, competition and informed and vigorous consumers would solve the problem. And you have the majority of healthcare reformers somewhere in the middle seeing a role for both government and for market processes, but in different ways. What you don't see is a consensus, and what you don't see is a willingness on the part of those who can't get their own way to agree that something other than the status quo is a good second choice. And the result of that is we have a continuing high decibel argument going on among relatively well-informed people presenting different solutions to the healthcare problem all unable to marshal majority support. Now, that's a pretty strong set of reasons why action is impossible, but I don't think that's correct. I actually think the stars have aligned better than at any time that I know of for making significant progress, and I'll try and talk about what that will be, could be, presently. But I'd like to go through some reasons why chances are now better than they have been in the past. First of all, business. At all times, all previous major efforts to achieve reform, right up through President Clinton's effort, large corporations, by and large, were extremely suspicious of having the federal government get involved in regulating something that played as important a part in their profit and loss statements as the checks they wrote for health care. They believed that through bargaining aggressively with insurance companies or with healthcare providers, by structuring insurance in ways that would promote intelligent buying by their employees, they could handle the problem, and they didn't want government mucking around in their affairs. It was a toe in the door. It could lead to worse. Please let us take care of it. And the result was that few industries have embraced government involvement in the healthcare reform process in the past. Those that did so were very tepid and only willing to acknowledge quite limited roles. That has changed in a big way. Businesses are now very concerned that they have not got the capacity to handle the very large and rapidly growing costs of health care. Changes that occur each year in unpredictable ways and constitute very serious business risks to them. They don't, by and large, believe what every economist believes, that the checks they write for health insurance eventually are offset by fewer wages or other fringe benefits, so the total cost of employing workers doesn't really depend on the cost of health insurance. They don't believe it. But even if they were persuaded of that, they would tell you, and I think correctly, we get surprised, we get big hits. They cause the increases in costs of health insurance come faster than we're able to adjust, and they are a significant business problem. So business has become a supporter of, rather than, many businesses anyway, rather than opponents of health reform. That is not independent of the rapid increases in the cost of care. They are abated during the mid-1990s and resumed with a vengeance at the end of the mid-1990s. I've mentioned the growing concerns about the quality of care in the United States. Among healthcare policy analysts, let me tell you, if you stand up and you say the U.S. has the best healthcare system in the world, you may provoke laughter, but you will certainly provoke dismissal as a serious person. In the broader public, the view is sinking in, I don't know how far it has sunk in, that there are serious shortcomings with the quality of U.S. health care. Here is something that has come on the radar screen and is new, completely new since the last time health care reform was a national issue. Starting in about 4 years ago, the Congressional Budget Office issued some long-term budget projections. By long-term, I mean stretching out about 75 years. Truth to tell, nobody can predict 75 years from now about the budget. Ask yourself what we thought about the budget a year ago today. And, of course, none of us was even remotely on the mark. But the projections for the long-term budget projections produced a graphic and story of such clear-cut character that even if there were big errors in it, the basic story was incontrovertible. We are running, in the long run, into expenditure obligations on the government budget way, 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 way beyond what revenues the current tax system will generate. And when I say way, way, I mean like 50% or more beyond what current revenues would generate. And the implication of that, of course, is big deficits, and the implication of that are growing interest payments on a growing debt, and the implications of that are that the deficit will grow explosively and become economically lethal, in the sense that you have a credit collapse or something of that sort, which provokes, of course, the old quip that economist Herb Stein once said, if something can't possibly continue, it won't. And in this case, the something that can't possibly continue are deficits of that magnitude, so they won't, but the question is, what do you do about it and what is causing them? Well, the answer is healthcare spending is causing them in these projections. 100% of the gap between spending and revenues is attributable to growth in projected growth in spending on Medicare and Medicaid. That accounts for it all. Take those two away or pay for them, and the rest of the budget's okay. No problems over the long term. Now, we can see what can happen in a year. You can get a lot of short-term events that can change your plans in a major way, but the long-term projections remain basically correct. Now, one of the people who was director of the Congressional Budget Office that issued this study is now OMB director for President Obama. So the one thing you know for absolute certainty is that at the highest levels of this administration there is a clear understanding of this long-term budget problem. And it is shared by Republicans as well as Democrats. The first report came out from CBO when it was directed by a Republican. The second came out from CBO when it was headed by a Democrat. No disagreement on that score. And the final, more favorable augury, the $100 billion number is not chosen at random. It is roughly the system-wide cost, estimated cost, of the additional services that would have to be provided if everybody was insured in the United States. I said the uninsured consume less health care. They do. About $120 billion is what it would take system-wide to cover everybody. Now, just as an aside, the fiscal challenge of insuring everybody is much bigger and more complicated than even that number suggests, because if you changed financing arrangements so that everybody was insured, you're changing a lot more who pays, who receives, state and local governments, corporations, the federal government, individual payments. There are many more changes in the cash flows than the $100 billion number suggests, and it's those shifts that are the real fiscal obstacle to taking immediate action. That said, after writing $750 billion checks for TARP and a stimulus package of $800 billion and God knows what else is coming down the pike, hey, $100 billion for national health coverage, piece of cake. Small chump change. Not quite, but you get my point. Well, let me now turn to what success might look like. There is a vigorous move afoot right now, led principally by Senator Kennedy, but with support from other senators and a few members in the House, to craft one large bill that would deal with quality, cost, and access. This is, broadly speaking, the approach that President Clinton took and that did not succeed last time around. So would it succeed this time? I don't think so. For many of the same reasons that affected President Clinton's initiative. Too big, too complicated, requires too much faith, conflicting jurisdictions, too many interests affected that adversely by any feasible reform who are well-funded and who can lobby Congress and help to block action. A political system still requires 60 votes in the Senate. And if you wonder about the unity of the Democratic Party behind any such proposal, I would ask you to take a look at the political reaction to President Obama's proposal to set aside $635 billion for health care reform over the next decade. Half of that money is to come from a tax change limiting the value of itemized deductions to 28%, so that anyone who faces a marginal tax rate greater than 28% would only get credit or tax reduction not at the marginal tax rate times your mortgage interest or your charitable contribution or any other deduction, 35% let us say, but only at 28% times the value of your deductions. So far, just to pick two names at random, two skeptics about that are Max Baucus, who's chair of the Senate Finance Committee, and Charlie Rangel, who is chair of the House Ways and Means Committee, the two committees that have to handle tax legislation. And I also would ask you to just speculate on how many Republican votes you think would be gotten for that. Well, let me turn now to what I think is a feasible evolutionary program of health care reform that I could imagine emerging from the current Congress and that could form a basis for action over this presidency and possibly later ones. I have 5 key items here, and as I will emphasize presently, they embody both conservative and liberal approaches to the issue. The first is the creation of what in his campaign platform President Obama called a health insurance clearinghouse. This idea is modeled on an actual legislative action taken in the state of Massachusetts to create a clearinghouse. There it's called the Connector. I don't know where they got the name, but the Connector is a name for a phone bank and an office through which individuals and small groups can buy health insurance, choosing among a set of plans that have met standards that the Connector establishes, which includes limitations on the differences in premiums that can be charged to people with different medical histories, ages, and so on. And the Connector also provides information so that individuals can get access to a fair story about the competing plans. This idea has been pushed very vigorously recently by a conservative foundation in Washington, by members of it, the Heritage Foundation. That paternity did not deter President Obama from embracing it because it's a good idea. And the reason it's a good idea is that it does good immediately and has the potential, I think, for being a genuinely fundamental change in our health insurance arrangements. What good does it do immediately? Well, the small group or individual health insurance market is a perfect poster child for a market that doesn't work right now. Insurance companies, for quite legitimate reasons, have to underwrite that is, to estimate the risks that clients pose for them and charge premiums to the extent that they are permitted that reflect those risks. Some states prevent them from fully incorporating all of that information, and they set limits on the variations in premium rates. Well, the connector would take that a further step so that insurance would be available right across the board to individuals and groups who can at reasonable rates. Furthermore, in the state of Massachusetts, the connector is the vehicle through which subsidies are channeled to low-income households. So that if you are a low-income individual not working for an employer, you go to the connector and you take your subsidy and you can find an insurance policy at a reasonable price, and the subsidy is set so that you do not have to pay an unaffordable amount out of pocket. Today, small groups and individuals. Tomorrow, that could well be the vehicle through which employers decide that they would like to encourage their employees to buy insurance. We've been sponsoring insurance for you and paying premiums. We'll stop sponsoring the plan. We will give you the premium. You can take it. We will give you the subsidy. You can take it to the clearinghouse and buy your own plan. Choose from among alternative plans. And if the pricing is fair, the access would not be impaired. Over time, the connector or the clearinghouse could be the dominant purchaser of health insurance, and at that point, a whole lot of other things become possible. I'll come to that in a minute. The second element, and one that's already been put in legislation, is to support publicly research on the comparative effectiveness of different medical procedures. Not doing it already, you might say, aren't we? Well, no, we're not. Most of what physicians now do has not been subjected to careful analysis of how effective that is compared to alternative treatments, or what the cost is per unit of improvement, measured unit of improvement in health status. We need to do a lot more of that, because it's going to turn out that much of what, some of what physicians now do could be done more cheaply. In some cases, more should be done. In some cases, interventions are very effective for some patients, but not for others. And knowing that can both improve the quality of care and possibly lead to some reduction in the rate of growth of healthcare spending. The third item is again one that has been around for a long time. It started as a conservative's idea, but it is embraced by analysts, both Republican and Democratic. Currently, when employers pay for health insurance, they get to deduct it, as they should. It's a cost of hiring workers, but the worker doesn't have to pay any tax on it. No payroll tax and no income tax. If the worker receives other income that it uses to buy other kinds of consumption goods, you receive the cash, you pay tax first, and then you only have what's left over to pay for everything else. So there's a big tax advantage to the purchase of health insurance relative to purchasing other goods, including paying for health care out of pocket. So that leads to a desire for more. In effect, the tax system is subsidizing or encouraging the purchase of health insurance, but it's doing so in an inequitable way. If I don't pay tax and I'm in the 35% bracket, I save a lot of money. If you don't pay tax and you happen to not be subject to income tax at all, and your employer gives it to you, well, you benefit to the extent that you didn't have to pay payroll tax on it, but you don't get the same benefit that I do. So the higher your income, the greater the incentive. That's crazy. It's crazy because upper income people by and large can afford health insurance, and lower income people by and large have a much harder time affording health insurance. So it would be better to have this, at least a similar subsidy across income brackets, and maybe a larger one down at the bottom. Furthermore, the subsidy that I get, the tax break, is the same if I'm paying extra for cosmetic surgery or cancer treatment. The encouragement, therefore, leads me to want to insure a lot of stuff that may be of relatively low priority. So the problem with the current tax treatment is it's unfair, it's poorly targeted, and it's unlimited. One element, and again, this is something that I would expect to see resurface because it receives support from both Republicans and historically, to a lesser extent, from Democrats, is a proposal to modify in some way the current tax treatment of employer-financed health insurance benefits. My preferred solution would be everybody gets a flat dollar credit, provided they have insurance that meets a suitable standard and the credit's refundable. So you get this credit whether you owe tax or not. And in addition, there is extra support if your income falls below stipulated thresholds. That's expensive. It can be anyway. And I don't know how far we'll move in that direction, but it's a promising direction in which to go. The fourth item is the Clearinghouse. I mentioned that as more and more people join the system, the capacity of that Clearinghouse to play an aggressive role in shaping the structure of insurance, in encouraging people to go to providers who have been shown to be efficient and high quality, increases. In short, this connector can evolve into becoming a major force for transforming the character, the way in which the organization of healthcare and the way in which it's supplied. And finally, healthcare is expensive. It's going to get more expensive. The budget projections that I indicated are very serious, indicate that deficits could be extremely damaging. There's a standard way in order to make sure that that sort of thing doesn't occur, and that is to link the financing to the expenditure. We actually do that with Social Security. There's a trust fund, payroll taxes go in, benefits come out, and whatever one may think of the current situation, the fact is that historically Social Security has taken in more in revenues than it's paid out in benefits. And that's going to continue to be the case for many years. So the final element I've suggested should be some trust fund-like mechanism into which an earmark tax flows and from which any subsidies paid to low-income people are paid that would make sure that, or promote a balancing of income and outgo. And as I said, this is a blending of conservative and liberal elements. It's the sort of thing that one could imagine garnering bipartisan support and being sustained when there are Republican presidents and Democratic presidents, because the proposal embodies elements that are consistent with the values and principles of both parties. Will that begin now, during the administration of President Obama? I think the jury is still very much out on this score. We are in the midst of a first-order financial crisis. The administration is betting all its marbles, really, politically, on being able to turn the economy around within the next year to 18 months. The Republican opposition has taken a very strong negative position. It more or less is, we think you're doing the wrong thing and you're going to fail. If they turn out to be right, then the Obama administration is going to have had a period of effectiveness as a governing entity. If the Republicans turn out to be wrong, if the Obama administration wins its bet, it will gain very considerable prestige, and it will be in a position to do a lot of the things that the president has been putting forward as his agenda. Which of these futures lies ahead of us? Invite me back next year, and I'll be glad to talk about it. Thank you very much.
Thank you very much. We have time for some questions. I'll try to get the mic so that
does the $2.5 trillion figure include over-the-counter and non-prescription medications, physical therapy, that sort of thing that wouldn't necessarily be through a physician's directive?
The answer is no and yes, respectively. It does not include non-prescription drugs. It does include physical therapy. Whether it includes something physical therapy not prescribed by a physician, I don't know the answer to that.
I'd love to hear your analysis of where all of the money currently goes that we spend as a nation. If France can do a better job for half the money, then where is our money going? Is it evaporating in corporate profits? Are we burning it someplace in a furnace that we don't know about?
It's a good question, and it's you might think that it would be one of those things that analysts would have a ready answer to, but they don't. The government prepares annually a breakdown of where that $2.5 trillion goes, and if you want to see it in detail, you can tune it up on your computer. Just look up cms.gov and go to the statistics section, and you'll see a whole series of tables that will break down who's paying for it and whether it goes to hospitals or doctors. But you're asking a much more interesting question, which is, why are the numbers as high as they are given the services that we get? To some degree, it's because we throw a lot of stuff at people during hospital episodes. And we have very short lengths of stay for that reason. You'd think short lengths of stay might be cheaper. They're not. The reason people get out fast is that there's a lot of technology thrown at them that enables them to, that completes treatment processes quickly. Prices of health care are higher in the United States than elsewhere. What does that mean exactly? Well, it's a very tricky question. Physicians in the United States, just to pick one example, have incomes relative to average earnings that are maybe 50% higher than they are in most other developed countries. It varies from country to country, so that one number does not fit all. But let's take 50%. The United States has many more specialists than other countries do. Now, that specialists routinely get paid more for their services than do GPs. And the reason is they've had more training and therefore, in effect, merit higher compensation as repayment for that. They're doing more complicated things. And therefore, some of that 50% reflects the mix of physicians that we have. How much? I can't tell you. Our physicians are paid on a fee-for-service basis. In many other countries, I don't know what the story is in France, There's a salary arrangement. U.S. physicians work longer hours. So part of that enters into the story. Now turning onto the other side, another place you can look on the web for genuine entertainment. You might not think health statistics would be most people's idea of fun, and maybe it isn't. But at Dartmouth University, for years, they've been collecting data on relative costs, relative spending under Medicare in different health service areas in the United States, and the relative use of different medical interventions. It turns out the variations are truly mind-boggling. For some procedures, the rate of doing things is 5 or 10 times as high in some places as it is in others. Can't explain this on the incidence of sickness. It's the style of medicine, what physicians are doing. They've also found that for selected conditions, health outcomes are worse where the most high-tech stuff is done. So now let's go back to the doctor story. Specialists get paid more. They're doing higher tech stuff. But it's not necessarily appropriate, which is where cost effectiveness research comes in as having one of the areas where it could have very, very large payoffs. Now, I've just picked on physicians' pay levels. And I hope I've given you a sense that it's not easy to explain why it is we pay docs more than other countries do, or what we get for it. The same is true with respect to treatment of heart attacks. Or we do an awful lot of hip and knee replacements. I'm standing here on 2 metal knees. Now, how much of that is merited? We do a hell of a lot of lower back surgery, and there's a lot of evidence that much of that is not medically indicated. So, is it price? Is it we're getting more high-tech stuff appropriately, inappropriately? The answer is yes to all of the above. I'm sorry I rambled on for so long, but the question you ask is fundamental, and we don't have a good answer to it. Or at least, or let me put it another way, we have a lot of answers to it, but they cut in different directions.
Has there been any analysis of our legal system and lawsuits with the medical industry, how much that costs?
No, nobody's looked at that. No, the answer is there has been a good deal of study, and the problem with our legal system and our compensation system for medical negligence are really rather different from that in conventional discussions. First of all, the impact on outlays, according to all of the careful studies that have been done, is relatively small. Yeah, the cost of malpractice, insurance premiums, kicks up practice costs in a couple of specialty areas, OBGYN, neurosurgery. It's a big item in some states, not everywhere. Second, it's not clear that the cost of malpractice insurance has been going up lately. It appears to have peaked a while ago and may have come down. Second, there have been studies of so-called defensive medicine, and yeah, it exists. Again, in certain areas, estimates as to what it could have added to the level and, a trickier question, the growth of healthcare spending. The general conclusion is some, but not hugely. But the system is a disaster. And the reason it is a disaster is that it doesn't compensate victims of medical negligence. A careful retrospective study was done where people went back and looked at case records. And the estimates are that about 1 person in 10 who suffers from medical negligence ever made it to court, and a tiny fraction of that, 10%, ever received any form of compensation. What we have is an enormously costly, overhead costly system that does a perfectly execrable job of providing compensation to people who merit some form of compensation. What we need is not, as many have proposed, caps on settlements. What we need is a system of dispute resolution that, first of all, encourages and rewards revelation of negligence rather than concealing it, and secondly, that handles compensation in a non-adversary fashion to provide help to victims of negligence. And guess who was were co-sponsors of a bill to do that about 4 or 5 years ago? Barack Obama and Hillary Clinton. I just hope he hasn't forgotten.
I was wondering if that estimate on cost also includes long-term care and what you see
Yes.
as needed reforms in that area of healthcare.
Oh, God. That's... you people have a talent for asking really rough questions. I think with respect to long-term care, there are at least 3 competing approaches, and I don't know which one is right. One approach to long-term care is that, well, let me back up. We do have a system of paying for long-term care. It's not a great one. It's called Medicaid. All you need to do is become poor enough, and then you receive sort of low-level but barely adequate support through the Medicaid program, and it varies somewhat from state to state. One approach is to say, look, a lot of people in the years before they die or after they become disabled require a period of nursing home care. So the thing to do is to provide a basic level of services that would cover nursing home care, if medical conditions indicate, up to a maximum. Beyond that, you have to use your own resources, Medicaid style, or become eligible for a public benefit based on low income. That's one approach. Takes care of most people who would ever have set foot in a nursing home. Then there's the opposite approach. The opposite approach is, in effect, catastrophic nursing home care. If you were in a nursing home for longer than a certain period of time, then a public benefit cuts in. Up to that, you're on your own. You buy long-term care insurance, you save enough, but you're responsible on your own. And the third approach is what is done in some European countries, which is to say that the public will fund facilities. They have a certain capacity. They practice triage. And that's the public involvement with nursing home care. The debate on what to do about long-term care has not gone nearly so far as the debate about acute care. It's not even really in a major way on the political radar screen at this time. And I have no idea how it's going to end up going. This is a long-winded way of saying, no, I don't have an answer, but I think it's also that the public doesn't have an answer either, the political system.
With that, I want to thank Dr. Aaron for a very thought-provoking presentation. Those of you with the name tags is lunch outside, and have have more conversation there. Thank you.